Good morning and welcome to How to Determine Which Articulator to Use. My name's Candace and I'll be facilitating today's webinar. I'd like to begin with a few housekeeping items. First, in the upper right-hand corner of your screen, you should see a questions box. Feel free to type in any questions that you have throughout the presentation. We'll be answering all the questions at the end of the webinar. The course is NBC approved for 1 credit. Within 24 hours, you will receive information on how to obtain that credit. We'll also be posting the webinar on our website in case you missed any portion or would like a review. I'd like to introduce our presenter, Jim Robinson. Jim is Whitmix's Institutional Sales Manager. Jim is a retired Air Force Senior Master Sergeant serving more than 22 years on active duty. Jim is a certified dental technician in Crown and Bridge. Jim's primarily responsible for managing more than 70 dental schools in the United States, Puerto Rico, and Canada, as well as all of the government business. He's also responsible for the overall management of Whitmix's involvement with continuing education programs throughout the U.S. He works closely with the Dawson Academy and the Seattle Study Club to lecture and present hands-on training for attendees. Jim?
Good morning. Greetings, and thank you for joining me in this webinar. As a representative of a dental manufacturing company specializing in articulators, I get asked by both dentists and dental technicians the following questions during many of the trade shows and meetings that I attend. Which articulator is best for me, or what are the advantages of having one group of adjustments over another? Of course, this question is impossible to answer without first knowing a little bit more about the type of practice the dentist has or the type or level of work the laboratory is providing. After getting this information, I can then start to help find an instrument that will provide the features best suited for them. So my goal after this presentation is to give you some information that will provide guidance when shopping for an articulator and help you understand what effect of using or not using the setting on the articulator has on the case. So let's get started. Articulators, or the concept of articulation, has been around for many years. It is not new. The first published paper on articulation was written in 1756 by Dr. Philip Hatt, a dentist in Germany. In his paper, he talked about putting the upper cast and lower cast together using his hands, and he studied the movement the casts were making as they traveled over their opposing occlusal surfaces. In my opinion, there are 4 basic movements that an articulator needs to have to simulate the jaw and its movements. Those being to be able to open and close in a hinge fashion, to move horizontally, side to side, to move anterior-posteriorly, like the protrusive movement, and to hold tight and centric occlusion during wax upper porcelain buildup. So with these 4 basic movements in an articulator, you should be well on your way to being able to provide a very sound quality product when you go to at the time of delivery to the doctor. Unfortunately, most of the early articulator development produced instruments like you see here on the screen, the Phillips occlusal scope, the McCullum gnathoscope, and even the simulator articulator. As you might expect, these instruments are very complicated and were not used for the full capabilities, just like some of today's fully adjustable articulators. And unfortunately, when the young dentists leave dental school and go into practice, they don't carry the articulator along with them because they feel it is complicated, and probably because they feel like they probably won't be doing maybe that high degree of that technical work, that type of work, as soon as they graduate from dental school. And manufacturers understand this as well. As a matter of fact, if you were shopping for an articulator today, you will find that most manufacturers have what we call fixed setting instruments. So as you start searching for an articulator, then you're probably going to find one that has a fixed setting, what we call intercondyle setting. This is most likely due to the research of Dr. Bonwell, who also is credited for patenting the first anatomical articulator. Now, if you look at this slide that I have up on the screen, this is Dr. Bonwell, where he actually took thousands of skulls and he measured the distance between the one condyle to the opposing side condyle and found that on average we fell pretty much within, or his measurements fell pretty much within 110 millimeters. Interestingly enough, when he measured the distance from the condyle down to the mandibular central incisors, that also became, or that was also 110 millimeters. So there became the theory of Bonwell's equilateral triangle, meaning that as long as the cast was mounted, or actually about 110 millimeters, we could work within Bonwell's equilateral triangle as we were building our case. So if you look at this slide next, then you see that on a newer articulator, as you see in this slide, the condyles are fixed. So they're not able, you cannot adjust the condyles from side to side. And they're set at approximately 110 millimeters. Most manufacturers, if they have an instrument such as this, where it's fixed, they also provide a stand where if you're arbitrarily mounting your cases or your maxillary cast, by placing it on the stand, you are falling within Bonwell's equilateral triangle, and therefore the movement should simulate fairly close to the average movement because of the distance between the average patient that he found in his research. So that you're going to be pretty close if you have an articulator that has this type of degree or this type of measurement between the condyles and the lower mandibular central incisors. Of course, now if you look at this, these two articulators you can see on the screen, you can see that they don't offer much in the way of functioning the way the jaw does. But basically, these articulators just open and close. So if you were out shopping for an articulator and you wanted to match what the jaw is doing, I would certainly say that you probably would not. You would want to have something a little bit more in the way of features than what you see on the slide. Now, you have a choice in articulator selection. So basically, so I'd like to do is talk about which one is the best for you. Now, studies have shown that over 95% of all the work general dentists will do when they graduate from dental school and throughout their career, their work can be done on a semi-adjustable articulator. There are a lot of times where certainly a fixed setting articulator, like you see on the upper slide, it's certainly usable. It's worthwhile to have in the practice. But if you're going to do any more extensive type of work, studies have shown that, again, most of your work can be done on a semi-adjustable articulator. And for a full-service prosthodontic practice, there's probably a need for a fully adjustable type of articulator, and most manufacturers still make a fully adjustable articulator, just like you see here on this D5A, which is manufactured by Denar. So why use an articulator? I think it's a very good question. Now, again, from Dr. Papp's study, he talked about, and we know that handheld casts provide information concerning the alignment of the arches, but they do not permit analysis of the functional relationship because, again, the wrists are not moving in the same manner or the same arc as it would on an articulator. So articulators are a valuable aid in also the diagnosis of the patient or the treatment that's going to occur, the treatment planning, where you can sit down with the patient with your cast mounted on the articulator and actually show them what the jaw is doing outside of the mouth. And hopefully the articulator is a valuable aid in the actual treatment or the building of the case, the manufacturing of the case in the laboratory. So our goal then is to find a mechanical device that will match the same position of the condyles as you would find on the lower jaw. So in this case here, the jaw is attached to an instrument, and you can see how it does match up with the condyles, about 110 millimeters. And our goal then is to, as we were to add the opposing or the maxillary arch to the case, we are building a case that matches and should be moving or functioning the same way that a patient does as the jaw would move in the skull or in the mouth. If we look at this picture, we also know that if we do this correctly and we're using a full-size articulator, as the jaw moves down the eminence, as you see here from the lines that are separated, you can see notice the separation of the teeth between the lower and the maxillary arch. And on our instrument, if we move the condyle the same distance down the slope of the condylar element, we have pretty much the same type of separation. So we are going to, in this case, we are matching up exactly what the patient is doing. Now, I also would like to say at this point here, though, it's very critical in order to get this exact movement to match what is going on in the patient. You have to use a face-flow registration in order to capture the exact cant position of the cast to transfer that over to the instrument. So very important to be perfectly, exactly perfect in your building of the case is to use a face-flow registration to complement placing it on a full-size semi-adjustable articulator. So why is a semi-adjustable articulator ideal for manufacturing most dental prosthetic appliances? Well, semi-adjustable articulators provide a very high degree of diagnostic information with the minimum need for clinical adjustments during treatment. And this is what is very, very important, is that if you use a full-size semi-adjustable articulator with the types of settings that are available, when you deliver the patient, or excuse me, when you deliver the case to the doctor, and he goes to insert that work into the patient's mouth, less time is needed because we're matching pretty close to what the patient has in their head when we're building it on a semi-adjustable articulator. When should you use a semi-adjustable articulator? I would certainly say that you should consider the extensive nature of the work that you're going to be doing. You should also look at the type of records that the doctor is going to be taking, and with those records, are you going to have an articulator that allows you to transfer that over to the instrument? Again, some cases the doctor may not be providing any records. There are some cases where you will not even need to set any type of adjustments on the articulator. But then again, if you have a practice or working with the doctor as a practice where multiple records are taken for the patient, then you want to make sure that you have an articulator that allows you to set that instrument up the way by the way the records are provided to you for you to use in that setting. I think we should also consider the patient's arc of closure in a semi-adjustable articulator. If you look at this picture, we have a full-size articulator, and as you see, as it's transposed onto the patient's head, the teeth are in the same position as you would find in a patient's skull or in the head. And also the condyle is in relatively the same position as you would find in the patient. So as the patient is opening and closing, the jaw is arcing. On the articulator, you're following the same track pretty much as the patient is doing. So this is very critical when you're doing those appliances, and we'll talk just a little bit about that in a few seconds. Also, you should maybe would consider having an articulator that you're able to adjust the patient's intercondylar width. If you believe in what Bonwell is saying, and most of our studies have shown that he's really accurate on the average settings, you may not need to have an articulator that has adjustment intercondylar width, but in case you do, just know that that is still available on some semi-adjustable articulators. So let's look at the patient's arc of closure. As I said earlier, we want to be able to use an instrument that opens and closes pretty much to the same arc as the patient. By having this, then that means that when you insert that case, when that case is delivered, then when the patient closes down, it's going to close in the same manner between what the patient is actually closing and that of the articulator. On a full-size semi-adjustable articulator, it more closely approximates the distance between the axis of rotation and the teeth. So the arcing areas will be minimal. So if you look at this picture that I have up for you, you see where there's the mandibular hinge axis on the patient on the mandible. And if you go and look at the articulator, the full-size articulator, the mandibular hinge axis is pretty much in this position. The articular hinge axis is just slightly, it's not exactly the same, but it's close enough to where the arc that the patient is, that the articulator is providing you is going to match up with that of the patient. So it's very critical. Because if you're not matching up on the same arc, then you'll have problems with inserting the case, more so in the posterior area of the mouth. Non-adjustable articulators, they're only good at maybe the intercostal position, and that's about the only place where they're going to be kind of repeatable and accurate. When you go to opening and closing, they're always going to be inaccurate. As you see from this photograph or this slide, the articular hinge axis is much smaller and much shorter as opposed to where the mandibular hinge axis will be located. So therefore, your arc is going to be different when you open and close as opposed to a full-size semi-adjustable articulator. So in doing so, then, if the doctor gets the case back and the technician has done some beautiful work on their porcelain crown, but when they go to insert, if they're having to grind quite a bit of the anatomy away, then that is probably a good sign that an articulator of a different size was used that is not matching up with the patient's arc of closure. And as you can see here, sometimes the farther back your units are, the more you're going to have to take away because, again, the arc of closure is not matching up, and therefore a lot of the work that you put into building this crown, these two crowns, is going to be destroyed because now you're having to take what was on the articulator, which looked beautiful, and going to the mouth because it is different. You have to take away a lot of the occlusal anatomy that was probably built into the case. Now, what I would like to show you is something that we see sometimes, and unfortunately, we do see this to some degree in some laboratories, and I would certainly have to compliment the laboratory and the technician for taking the time to make this beautiful mounting on this articulator. But from what you've already heard me talking about, the intercondylar width is going to be much shorter on this articulator, and also the distance from the condyle to the anterior portion of the tooth is much shorter on this case. And so if you look at this, a lot of time and effort was put into mounting this on an articulator. Actually, a bite record was even provided to get the bite accurate. But what you don't, maybe what you've noticed, or what I would like to point out is, with this type of articulator, there is no use, or there is no way to attach a faceball registration to this instrument. So therefore, if you look at the curve of C, which you would normally find in the maxillary arch, there's actually almost a backwards position of how this upper cast is mounted on the articulator. So there were no records provided except how to close the two together, but the records to actually put this on an instrument without a face bow really is making this a case that's just doomed to failure from the very beginning. So certainly choosing an articulator is very important, but knowing when to use a faithful registration is also very critical when you're working on these types of cases. So certainly, if you're doing a multiple units or full mouth rehabilitation, you want to take and use an articulator that would give you the best chances for success as you go and start working on that case. So selecting the instrument really is based on, as a dentist, the needs of your practice, or in the laboratory, the type of service or the work that you want to provide your dentist. And sometimes it's based on your philosophy of dentistry as far as the dentist is concerned. Do you believe in progressive side shift, or maybe you believe in immediate side shift? And do you want to have adjustable intercondylar width? And also the setting the articulator. Are you going to be using the articulator quite a bit as far as setting it up using lateral and protrusive records? These are things that you have to think about as you start to kind of understand what type of instrument do I need to have for my practice or for my laboratory. And you would need to work as a laboratory. You certainly need to work very closely with your dentist to understand their ideas, their philosophy on the types of settings that they want from you as their laboratory. Another couple of things you want to consider in your articulator selection is, are you comfortable with what we call an open faucet design? With this design, if you look at this picture on the left, what we have is we have the condylar element, which is basically just resting on or sitting on top of the condyle, the ball of the condyle. Now, this is very popular for technicians who do crown and bridge work, because with this design, they can very quickly release the upper member from the lower member to work on maybe their wax dust or maybe putting porcelain on the crown and then putting it back together and closing down and kind of getting their contact. But it's very easy to use because it can be released and removed from the upper member very quickly. Or are you comfortable with a closed tracking design? In this design, as you can see, the condyle or the ball of the condyle is locked in a closed, we call it closed track. So the upper member cannot be removed from the lower member during its use. Very popular in dental schools where young dentists are being taught how to do a denture setup. Because in a denture setup, you don't want the cast to be separated from the lower or from the wax as you're setting denture teeth. And for the students who are learning how to set teeth for the first time, if their wax starts to get cold before they actually get to finish the setup, there is a chance that as they close the upper member down with an open faucet design, that the actual upper member would lift off slightly because the tooth was actually not being pushed down in the wax far enough. It's actually raising the condyle off the condylar ball. However, with this design, as you can see, the upper member cannot become separated. So when you close this articulator down against the lower cast, it actually forces the tooth into the wax, and then the wax can be reheated and repositioned in the correct setting. So this is very popular with those laboratories or those dentists who are doing the removable type of work. Another consideration would be is are you more concerned with or my slide isn't working? Trying to get my slide to move forward. There we go. Are you more comfortable with a straight tracking faucet design? So we go back and look at my picture here on the condyle. This ball is nothing but a flat surface that the ball is riding on. Now this is kind of it depends on, because our TMJ in this articulator it's mechanically simplified, but it does not produce some of the condylar movement. So if we look at this drawing here in the circle, we know that when the condyle is in CR and it starts to track down the eminence, it starts tracking at a much steeper setting as opposed to when it starts to reach the end of its track where it kind of shallows out. So if you're using a straight type of tracking faucet, that would mean that in order to follow exactly what the condyle is doing, you may have to set the condyle at the beginning at a steeper angle, but then when you go to position number 2, as in this design where the condyle actually levels out a little bit, you would have to almost set the condylar element again to a much shallower setting, so that you start out with a steep beginning, and then at the end of the track you would want to be shallower. The straight tracking condylar design cannot do that exactly the same as the condyle is moving. So therefore, we do make instruments, or articulator manufacturers do make an instrument that does have a curvilinear design, as you see in this photograph. So here, as the ball leaves the mechanical instrument, it does follow a steeper curve like you would find in the anatomy of the jaw, as you see in this picture here. But then as it gets towards the end, it levels out. So the curve in minutia is a popular type of design that most manufacturers do manufacture, and you'll see them highlighted as either a 3/4 inch radius, or some they'll say a 19 inch or 19 millimeter radius. Okay. So there are different ways that they would identify them, but just know that if they're talking about a curvilinear design, they'll have them listed as a 3/4 inch radius or something in that nature. Another thing that you would want to consider is what are some of the settings that you're going to find most semi-adjustable articulators. All articulators will probably have, if they're semi-adjustable, will have the ability to set the congruent inclinations. And you'll find those either on top of the instrument, or here on this instrument, you find it on the side, or on this design of the instrument, you find it actually on the bottom of the instrument. Most of them you will find the ability to set congruent inclinations. Some instruments you have what is called a progressive side shift setting, and on some, you will have what is known as a fixed setting bend angle, which you don't see because it's underneath this metal piece, but they will have what is known as an immediate side shift. So as you start to look at instruments, again, depending on your philosophy, you will have some idea of what you think that instrument needs to provide in the case that you're going to be working on. This, if we go back to this picture here on the left-hand side, the upper left, this instrument gives you the ability to set intercondylar, have an intercondylar adjustment. Also allows you to set a protrusive bend angle as well as immediate side shift. So this gives you 3 of the types of settings that you will find on most semi-adjustable articulators. So now what we're going to do is let's talk about what are the effects of these settings on the articulator. What do they do, whether you use them or not, and we're going to go into each one of those in just a little bit, in a little detail. So we'll look at what effect does immediate side shift have on the case. And let me begin by saying that there are different philosophies in whether or not immediate side shift is even probable, or whether or not you can even set immediate side shift on a patient, or find immediate side shift on a patient. And again, so in that school of thought, when you push the condyles and back into the fossa all the way where they're fully seated, there's certain schools of thought that say that there's no way you can find or you can have immediate side shift because it's fully seated and it cannot move. However, there are some schools of thought that think there are some instances where immediate side shift is certainly probable, or that you will find it in a patient. And some of those would be from patients who are maybe severe grinders. Over the years, there is just some belief that over the years, as grinders through all their lives, there may be some wear, some deterioration in the fossa element, in the area of the condyle and the fossa. Certainly, if a patient has had a severe head trauma, maybe in a sports activity, or maybe a car accident where maybe they damaged the mandible, and maybe also some damage to the condyle. And of course, there are maybe some health issues with just some deterioration of the condyle. So there are some individuals who do believe that immediate side shift could be present. And certainly, if it is, then you want to be able to program that instrument, and you also want to be able to set up your case to actually match the actual movement that the condyle should be making. Now, in this drawing here that I'm going to show you, or that you're looking at now, you can see where if immediate side shift is available, in this case here, there is a slight shift of the condyle in this direction you see by the arrow, or you see by this drawing. And what happens is, on a normal progressive side shift, when the condyle starts to move down the eminence, it follows just a fairly straight path. But if you look at, if there's immediate side shift available, you see here where in this design, the belief is that there's a slight shift of the condyle, and then it follows a progressive path. So if this is true in your patient, and also one more thing I would say about immediate side shift is really the only way you're going to know whether or not there's immediate side shift is you have to have some type of mandibular recording device that will give you that information. You can't just have a patient sit down in a chair, push their jaw back, and try to move it side to side. You're not going to be able to tell immediate side shift from doing that. It just won't work. So if you have a mandibular recording device or mandibular tracing device of some sort, then you can probably take the patient through all the different movements of the mandible, and that if immediate side shift is there, it will show you that it is present. And if it is, then you will need to build that case in order to introduce the side shift before you go into your progressive movement. So that's what's important. And if you look at the slide or the picture to the right, basically this is showing you what the cusps are doing over the opposing surfaces in working or also in balancing. So if you look at this photograph, you'll see that the teeth track with a shallower or with a straight progressive, but if there's a medial side shift built in, then it's going to shift a little bit and it's going to follow some similar track, but you can see there is a slight difference in the way the tooth is tracking over the opposing surfaces of the teeth. So that's what you would need to be aware of if you have a case where you need to build in immediate side shift. Now, what effect does the Bennett progressive side shift have on the case? In this picture here, we show that you can set the Bennett side shift from 0 to 30 degrees. And again, depending on the manufacturer, depending on the study of the dentist that was used in developing a lot of these instruments, you'll have differences in how far the immediate side or the progressive side shift may go. In ours, on the Whitmix Articulator, we're using studies by Lundin and Gibbs, and also Dr. Charlie Stewart, who actually came to this company with his first design of a more simple type of stem-adjustable articulator. Same here, then what we're looking at then is if you have a progressive side shift that's very small or low in this picture, 5 degrees, you'll see that the track is going to a certain arc as it travels out of its contact position over the surface of the tooth. However, if you had a progressive side shift that was a little bit larger, then you would see that the tooth is going to track in a different arc, a little different position, in both the working and the balancing side. So again, very important if you are trying to build a case that you want to match it exactly what the patient has, or you're trying to build a case from start and you want to produce a Bennett side shift. Normally you can have the patient go through, again, either through recordings, or you can actually do a lateral record, and it will kind of help guide you or show you where that progressive side shift should be set on the instrument. So, but this is showing you what the difference would be between a low Bennett progressive side shift or a higher one, and what happens if you don't program the instrument to follow the exact same path that the patient may have in their working dentition. And what effect does the counter inclination have on the case? What we have here is most patients, from some of the studies, would be most patients have an incline of about 45 degrees on the inclines of their cusp. However, if you build a case at 30 degrees, what you're actually doing is you're actually making your crown that you're building a little bit shallower than what the patient would have in the mouth. So what this does then is when the case is delivered and the doctor puts it in the mouth, because if you build yours at 30 degrees and shallower, there's not going to be any interferences as the patient goes through their excursive movement. So again, we know that if the patient has a higher degree, and most patients have on average about 47 degrees on a healthy tooth. So if we build ours a little bit shallower than that, then we know that we're not going to have any interferences. And there are times where if you have a case that comes into the laboratory as a technician, your dentist may not provide you with lateral or protrusive records. In this case, if you look at the manufacturer of that instrument, they will certainly give you some guidance as how to set the articulator for those cases where you don't have records that you would set the instrument with. And again, we're using average studies or average numbers that have come about from studies over many, many years by many, many different dentists in looking at these types of effects on occlusion. So 30 degrees is a very safe number to go with if you don't have a protrusive record. But if you have protrusive records and you want to match exactly what the patient is doing, then this is what setting the articulator will do for you. If you have a patient and if you take a protrusive bi-record and you adjust the articulator and it comes at 45 degrees, then you know that by setting the counter inclination at 45 degrees, you're matching exactly what the patient has in their dentition as you build your case. Is it important to have an instrument that has adjustable intercondylar width? As stated earlier, if you believe what Bonwell is saying, then maybe the answer is no. Maybe you don't need to have adjustable intercondylar width. However, there are manufacturers that still sell articulators where you can adjust. And as you see from these pictures, the small setting here is at 96 millimeters, and the medium setting on this instrument is at 110, and the large setting is at 124. I can tell you with many laboratories that I visit, and I see this articulator being used in the laboratory, almost every instrument, if not every instrument, they're set at 110 millimeters or at the medium setting. this just follows and kind of holds truth to the theory of Bonwell when he said on average 110 will work for most patients that you do dental work on. So if you have the need or you feel like you have to have an instrument that gives you adjustment in condylar width, this slide is just showing you the differences, again, the tracking of the tooth over their opposing forces between a large or wider intercondylar width and that of a smaller intercondylar width. So you see from the two arrows between the A and the B, A being the widest, the tooth will follow a certain track, as you see on this photograph. Or if the intercondylar width was much narrow, the tooth is going to follow a much different track than if they were larger. So again, it's going to be critical if you're building a case and you want to match what the patient is doing. Now, I would probably say that these averages are pretty skewed, where probably the A may be about 140 millimeters, and the B may only be like 96 millimeters in this drawing. They look fairly far apart. But if we were to take the average of the two and put them in between, we're going to be right about 100 and maybe 110 millimeters. Now, a drawing I'd like to show, or some pictures I would like to show you, is from a presentation on occlusion that was done by a very knowledgeable technician, Al Filastri, and when I saw this, it really did just made some great sense, and really put the picture in perspective of what we were talking about when we talk about intercondylar width between a full-size seam-adjustable articulator and a smaller fixed instrument. So what he did was he took a paper, and he laid the articulator, as you see, on the paper, and he put some marks on the cast, just kind of give him some landmarks to start with, and then he drew the positions of the condyles on this piece of paper. And then he took a smaller articulator, a very popular instrument that's used out there, took the same set of casts and mounted those placed this on the paper, and also drew a circle of where the condyle was. And then from there, he took a compass and he measured the track, the arc, or the track that case would take between the small straight line articulator and that of the full-size seam-adjustable articulator. And from this, you can see that the track is definitely that does not match up. So, of course, this would tell me, and I hope it could show you, that anytime you're doing a large, more extensive type of work, it certainly would behoove you to probably use a full-size seam-adjustable articulator so that you're going to match the same type of track that the patient has. So, I think, again, it was very easy for me to see this and understand this a lot more as we talk about the intercondylar width and how important that is. If you look at this picture, these are just drawings that kind of show the same thing. It shows you between a small articulator that's mounted where there is really no intercondylar width, or the track is very small. Shows you where the mandible tracks, and it shows you where the articulator tracks. You see there's quite a bit of difference in the tracking position, or where those teeth or cusp are riding over their opposing arches, as opposed to if you have the same cast mounted on a full-size seam-adjustable articulator. You can see where now between the mandible and the articulator, it's much closer. So this would show, again, show you that anytime you have an opportunity when you're doing your larger cases, you want to mount them, if you can, on a full-size seam-adjustable articulator to match up much closer the tracking that tooth is going to take over the opposing surface. And then one more thing about this is some pictures he showed was he took the straight line articulator and he actually mounted it on a full-size instrument just to show you what this does from I guess a different perspective, a different view. So on a full-size articulator, as you see, when we go into our lateral movement, you can see where the cusps are riding. You see actually how close the cusp tips are on the full-size articulator. But on the smaller hinge type, you can see that because it's riding in a whole different track, you notice that the differences in the amount of space that is open between the smaller hinge type articulator and actually the context that you're getting on the full-size tracking type of articulator, or the full-size semi-adjustable articulator. Now, if I were to look at this as a technician, I might think that I have room to add more length to my cusp tips because I'm pretty far open. But if you really, once you put it on a full-size tracking articulator, you would see that basically if I did add some, I would have had to reduce it because it doesn't match up. Now, of course, you would not know that until you went to the mouth. If you built it on this and you added your length here, if this is the only articulator you had, you would not know that you had the differences in length until you went to the mouth and the patient really went through the movement and really was closer to what you see in the picture on the upper left. So if we look at this real closely, we can see the tracking of the cusp or the opposing tooth. between the two types of articulators. We can see where we have a presumed open gap between the bicuspids, in this case, and where they are touching on the full-size tracking articulator. And so that tells you, again, a good reason to want to use a full-size instrument as opposed to a straight line for a case, even a case that is only the 3-unit bridge. So you see there will be some adjustments that would have to be made at the time of delivery. Now, what this all is adding, or what I've been talking about is, as you're thinking about an articulator between a non-adjustable or semi-adjustable articulator, you need to understand, or I hope you can look at this chart, and it kind of shows you what you have to select from when you're thinking about an articulator or the type of case that you're going to be doing. So for what's important here, though, is I think is with the chair time that's needed for cementation, if you use a non-adjustable articulator, the increases quite a bit more the chair time that's needed to insert those cases because of some of the settings I've been telling you about, or certainly the larger size instrument as opposed to the straight line articulator, whereas opposed to using a semi-adjustable articulator, the chair time needed is much less. Certainly the fully adjustable and semi-adjustable articulator are great when you're doing multiple opposing restorations, certainly where there's no anterior guidance or there's extensive occlusal pathology. You want to use these type of instruments from those cases that you're working on either through your practice or within the laboratory. There are times where certainly a non-adjustable articulator would be fine, but it's really only, I would only recommend it when occlusal influence is very minimal. Otherwise, you will have issues, or you run into problems with remakes or restaining of the portion crown restaining because of the adjustments that have to be made, and we know that takes time away from our production as we're working on other cases that we have at our bench. Another slide that kind of stresses or shows this would be on a non-adjustable articulator, the ability of what type of information that the articulator can provide is very small, or is very compared on a non-adjustable articulator. However, the adjustments that is required by the clinician at the time of delivery is quite extensive, quite the amount of time that's needed. Whereas on a semi-adjustable articulator, the amount of information that you can gather and add and build into that instrument from the records that you might take is quite a bit more. And the time to insert the case at the time of delivery is taken down quite a bit as opposed to a non-adjustable. Now, for those who still would be interested in a fully adjustable articulator, certainly the information you can provide or that you can add to the articulator is almost almost unlimited. However, you would need to have a mandibular recording device in order to give you all that information. But when you go at the time of insertion or delivery of the case, you can see that the time is very, very small as opposed to a non-adjustable articulator or something that is much simpler. So as I wind up this presentation, I want to go ahead and again kind of stress the importance of having a full-size semi-adjustable articulator with the different types of settings depending on your philosophy and what you feel you need to have in your practice or in your laboratory. But the important thing about semi-adjustable articulator and a full-size semi-adjustable articulator is, as I said at the beginning, is it places the teeth in the same position on an instrument as you find in the patient's head. The condyle is located pretty much in the same position on the articulator as you would find in the patient's skull. So the arc of closure between the patient and the mandible's arc of closure on both the patient and the articulator are going to be very similar or to match up almost exactly the same. Then again, I talk a little bit about what you find or what you will see some in a lot of labs would be the use of a smaller type of articulator. So on this photograph, you see that the caps or the teeth are still located in the same position on the patient's face. But what has changed is we've moved the condyle down from where it was located on the patient, where it's located in the patient's skull, but on the instrument it has dropped, and also it has become shorter from the distance from the condyle to the anterior teeth. So if you look at this picture, then the arc of closure has now changed from where it should be to a much smaller arc on the instrument. Now, this is where if the case is delivered and the doctor goes inserted, and then he or she comes back and says, I had to do quite a bit of adjustment on the posterior crown, and you may ask the question, do you think the case was mounted enough, or did you take it out of occlusion enough? And certainly if you put the work back on this articulator, you'll probably see that on this articulator it is perfect. The occlusion is probably perfect, spot on. and it was probably mounted correctly with whatever records were provided, if any. And that would be true because it would work on this articulator in this arc of closure for this size. But when you go to the patient's mouth, the arc is different. So therefore, you're not matching up exactly the same as you should. And then finally, as we showed you on the design that Alpha last week showed us in the photographs, this is a very popular articulator. And so as you can see already, the location of the teeth hasn't changed, but the condyle has moved dramatically from its position where it should be. So from this gold position down to this orange position, much, much shorter. So now you can see how small our arc of closure is. With this type of case, if you're doing multiple units, and more so to the posterior, and even some in the posterior, but most of the posterior, you're going to have quite a bit of interference when you go to insert that case. This is probably going to occur, what's going to occur in this is the photograph I showed you where all the anatomy is ground away. No matter how much time you put in making a nice, beautiful crown with nice, perfect anatomy, if you put it on this instrument, it will look nice. But when you go to the mouth, there's a high likelihood that the dentist is going to have to reduce or eliminate all of the anatomy that you may have built in due to the arc of closure not matching up with that of the patient. So the goal in the presentation that I tried to provide was, when you're thinking about or looking for an articulator, a semi-adjustable articulator is going to be probably your best option for what you need to use in lab or in your practice. Just know that you have multiple articulators out there on the market. They're all going to have different types of settings. I think from the presentation, I kind of tried to show you what the different settings do to the case, and basically they all have to do with the arc or the type of the surfaces or where the cusps are going to follow over the opposing surfaces, and each setting has a little different angle. Will give you a little bit different angle on how the cusp is going to ride. But once you understand, and if you take records and you're able to use your instrument that has the ability to set that instrument according to your records, you're going to have a much higher rate of success when you go to the patient. But if nothing else, if you have a full-size semi-adjustable articulator that matches the arc of closure closer to that of the patient, you will also see that you're going to have a much higher rate of success as you go to manufacture those appliances, and certainly as you go to deliver them to the dentist. And when they go to insert that, they're going to find that they don't need as much time at the chair to insert that case, because we've already tried to take some of that into play when we use an instrument of size, a full-size articulator. So hopefully the information I've given you this morning will help you make a better decision, or at least something to think about when you try to go shop or look for an articulator. And certainly if you have any questions, you can always contact personnel such as myself at Whitmix to give you more information or give you some advice on how to look for an instrument that will best meet your needs either at your office or in your practice. So I want to thank you for joining me, and I will take any questions that you may have.
All right, thanks, Jim. We do have a couple questions. The first one's, I think all of our articulators are fixed settings. Should we look at replacing them?
And as I said in the presentation, there will be some cases where if you're using a fixed setting instrument and most of them will be at average settings. According to the studies that have been done, average settings will get you through most of the work that you will do in your practice, unless you're a prosthodontist and you're really doing the more extensive work. So I would say there's not a need to maybe replace a fixed setting instrument. I think what's important, though, is as you look at that instrument, see if it is a full-size articulator. There are many full-size fixed setting articulators that manufacturers have available, and you're going to have a better rate of success if at least your articulator is a full size.
Okay. And how important is interchangeability?
Interchangeability is different than certainly the topic that I had. Interchangeability is very important for if you're a high production laboratory or you're working with a dentist who wants to send only the cast to your laboratory. But interchangeability is really only successful if you keep the articulator in the areas like the fossa elements or the condyles. If those have to be clean of any debris, wax, or stone, and in particular the areas where the mounting plate comes in contact with the upper member or the lower frame of the articulator, those areas have to be absolutely clean of any wax, stone, or other debris in order for interchangeability to work. Interchangeability is important if you're wanting to maybe minimize purchasing multiple articulators and you're just using your cast on certain instruments. But in order for interchangeability to work, you have to really follow a pretty stringent cleanliness of the instrument and of the mounting cast that you're going to be mounting against the articulator.
All right, well, thanks, Jim. That concludes our question and answer portion. Just a couple reminders. In 24 hours, you'll get the information required for that NBC credit. And if you have any further questions, just shoot us an email at webinar@whitmix.com. Thanks, and have a great day.